Hello everyone, this is Dr. Ochoa, your Pathway to Wholeness Medical Director. Today, we will cover the subject of aerosol transmissible disease, or ATD training. Following this session, you may be left thinking, why did we have to review some of the material presented? The answer is that the content of this presentation is required by Cal OSHA, the details of which are codified in Title 8 of the California Code of Regulations, Section 5199. With that caveat, let us begin. So what is an aerosol transmissible disease? It's defined as a disease for which droplet and airborne precautions are required, and these include two different infectious categories spread by two different means. One is aerosol and droplets, and the other is airborne. So aerosol transmissible pathogens are transmitted by infectious particles or droplets coming into contact with the eye, upper respiratory tract, or mucous membranes of the nose and mouth. For example, pertussis, or also called whooping cough, and influenza. Airborne infectious disease are transmitted through the air. For example, tuberculosis, measles, and varicella, also referred to as chickenpox. Now, let's look at the relevant precautions and the recommended personal protective equipment for each of these. Contact precautions, these require gloves and gown. Droplet precautions, this involves coverage of the eyes, nose, and mouth. A surgical level mask is recommended for our staff and for patients, and eye protection can include things like shields or goggles. And lastly, airborne precautions. This requires an N95 fitted respirator for our staff. Here's a more detailed list of the two pathogen categories, and if you look on the left-hand side, you see the airborne infectious disease. That includes some of the ones we mentioned: varicella, measles, tuberculosis, but also includes a few things we don't always think about: monkeypox, avian influenza, and as the table says, any other disease for which public health guidelines recommend airborne infectious isolation. Looking at the right-hand side of this slide, everything else that you might think of is there amongst the aerosol transmissible pathogens. Prominent among them, you see varieties of pneumonia of all kinds, streptococcal disease, meningitis, whooping cough, also referred to as pertussis. Note that SARS is in both categories. Also note that COVID is not in these tables, so we'll have something to say about that. So let's look at one more type of precaution referred to as standard precautions, and this applies to care of all patients in healthcare settings and include the following: hand hygiene, personal protective equipment, respiratory hygiene, and cough etiquette. Cleaning and disinfection of devices and environmental surfaces. For shared equipment such as a stethoscope, cleaning should be after each use with an ethyl alcohol containing product of at least 70%. Now, the World Health Organization guidance for healthcare workers who are caring for confirmed or suspected cases of COVID-19 recommends the use of standard, contact, and droplet precautions, with a qualification for the instances when you have to take airborne precautions. So, airborne precautions, or in this case the N95 respirators, should be used for any aerosol generating procedures, again according to the World Health Organization. And their list of these procedures would include the following: manual ventilation before intubation, CPR, and curiously enough, dentistry procedures. There are additional mask guidelines from the California Department of Public Health. However, as of April 3rd, 2023, guidance is based on CDC COVID community levels. So what about screening? According to the ATD guideline, healthcare providers will use their knowledge to screen patients. Now, we expect that during most mobile clinic operations we will have a licensed provider present. But what if we don't have a licensed provider? In that case, we will be using some principles out of Appendix F, which is in our ATD policy. And the two basic questions fall into these two categories. Number one, does a patient exhibit cough more than 3 weeks that is not explained by a non-infectious condition? For tuberculosis in particular, additional significant findings would be unexplained weight loss, night sweats, fever, chronic fatigue, malaise, coughing up blood. All of those would suggest tuberculosis. The second question is, does the patient exhibit signs and symptoms of flu-like illness during March through October, which is outside of the normal period of influenza, or exhibit signs and symptoms for a period longer than 2 weeks at any time of the year with any of the following symptoms: cough, rhinitis, which is a runny nose, fever, sweating, chills, body aches, and malaise. Patients, however, who exhibit flu symptoms during flu season do not require referral or transfer. What if we have to transfer a patient? Under the 5199 standard, clinics like ours are classified as, quote, referring employers, end quote. This includes clinics that screen for airborne infectious disease but do not provide care beyond first aid, initial treatment, screening, or referral. We are therefore distinguished from other institutions like hospitals who have other requirements under the standard. From our ATD policy section 4, the following quote: providers referring patients with suspected airborne transmissible disease will communicate the clinically suspected or presumptively positive diagnosis by point of care testing to the receiving facility, if applicable, to the receiving physician, for example, at a receiving hospital. Now, section 4 of our ATD policy has more details on referrals, and the San Bernardino County Department of Public Health 24-hour number is listed here for reference. The following is verbatim from our own ATD policy, section 5. Where feasible, a patient being evaluated for an ATD should be assessed away from other patients. Should it be identified after initial triage intake that a patient may have an ATD and is in an exam room on board the unit, the room will serve as the location of temporary isolation. Source control mask, such as surgical and procedure, will be given to the patient. If a patient does not comply with source control measures, then volunteers of the clinic who have contact with the patient must wear an N95 respirator. Use of standard precautions, as noted in slide 4, will be followed. Droplet precautions are recommended while evaluating patients with symptoms of respiratory infection, particularly if fever is present. So the ATD standard requires source control measures. So verbatim from our policy, section 2, under source control procedures is the following. Source control procedures include the following: posting signs near entrances instructing patients to inform healthcare staff if they have symptoms of respiratory infection, posting information about respiratory hygiene, cough etiquette, surgical or procedure masks and tissues to be made available to symptomatic patients, placing symptomatic persons in a separate area or room. This may involve having patients wait in their vehicle, a separate waiting area, or a designated exam room within the mobile. Make available hand-washing measures with alcohol-based hand sanitizers to patients and persons that accompany them. Method of informing. This may take the form of clearly available or posted procedures, hand-washing materials, and source control measures such as masks. So let's summarize when to use respiratory protection. And as we mentioned, the California Department of Public Health has its own mask guidance. For patients, when presenting with a possible ATD, offer a procedure or surgical mask. So what about providers? When evaluating patients with a possible ATD, surgical or procedure mask is acceptable for diseases with droplet precautions. Other PPE, like face shields, gloves, and gowns, may be recommended, for example, when fever is present or based on CDC community levels. N95 respirators should be used in the following 3 circumstances: airborne infectious disease known or suspected, in patients with ATD symptoms with a fever of unknown cause, And lastly, in patients with ATD symptoms who refuse to wear a source control mask. N95 respirators, or masks, are categorized as air purifying respirators, or APRs, which are disposable and have a filter efficiency of 95% and an N category of resistance to filter efficiency degradation. In this instance, N stands for non-resistant to oil. Another aspect with regard to N95 respirators is their assigned protection factor, or APF, and this refers to the workplace level of respiratory protection that a respirator is expected to provide. An APF of 10, for example, means the respirator is expected to reduce the user's exposure to an airborne contaminant by a factor of 10, and this is the requirement for half-mask respirators. Improper use or fit of a respirator will limit its effectiveness. Refer to the fit testing section of the ATD policy for proper fitting. Medical services for employees are required under the standard and are found in Section 6 of our own ATD policy. So verbatim from our latent tuberculosis TB surveillance program, the following. TB assessment is done annually by tuberculin skin test or a blood test called an interferon gamma release assay. Volunteers who experience a TB conversion must be referred to a physician or other licensed healthcare professional for evaluation for active TB and for advice about latent TB infection. The physician or other licensed healthcare professional shall determine if the volunteer is a TB case or suspected case, and if so, shall follow the procedures in the ATD policy for reporting and an opinion on precautionary removal from work if active disease is suspected. Other medical services for employees include vaccinations. Seasonal flu vaccination is to be made available. Other vaccines to be offered to employees are noted in Appendix E and include measles, mumps, rubella, Tdap, and varicella. Volunteers are permitted to decline any recommended vaccination but must sign a statement for each declined vaccine. Under the bloodborne pathogens requirement, we also need to make hepatitis B vaccine available. Vaccine information is required under the standard. For varicella zoster, the schedule indicates use between age 13 to adults, 2 doses, and persons without evidence of immunity. For healthcare personnel, the Advisory Committee on Immunization Practices recommends evidence of immunity or have received 2 doses of vaccine 4 to 8 weeks apart. Post-exposure vaccination is also available. Regarding efficacy, 1 dose is 82% effective and nearly 100% effective against severe varicella. 2 doses result in 98% effectiveness at preventing any form of varicella and 100% effective against severe varicella. Post-licensure 2-dose efficacy rates range from 88 to 98%. Lastly, safety. Contraindications for varicella vaccine in adults include anaphylactoid or anaphylactic reactions to gelatin, neomycin, or a vaccine component, leukemia, lymphoma, or marrow cancers, receiving immunosuppressive therapy, including large doses of oral steroids, and lastly, is the patient or might the patient be pregnant? Cautions in adults. Within 11 months following blood products. Common reactions include pain, redness at the injection site, and fever. Rare reactions, the following: pneumonia, infection of the brain or spinal cord coverings, or seizures. Zoster, also referred to as shingles, is rarely associated many years post-vaccination. So let's look at 3 additional vaccinations in regards to their schedule, efficacy, and safety. For influenza, it is given annually age 6 months and older. It is ideally offered in September or October, but is administered through the flu season. The reported efficacy variability from 2004 to 2022 was from 10% to 60% post-vaccine influenza outcomes. It is contraindicated if there is a history of anaphylaxis or any flu vaccine or its components. It's contraindicated if Guillain-Barré developed within 6 weeks of a vaccine. It is no longer contraindicated for egg allergy. Now to measles, mumps, rubella. Adults are given 2 doses 28 days apart. Evidence for immunity is as follows. 1 or more doses after age 1 for those not at high risk, 2 or more doses for adults at high risk, including healthcare personnel, lab evidence of immunity, or lastly, birth before 1957. Regarding MMR efficacy, for 1 to 2 doses respectively, measles 93% and 97%, mumps 78 and 88%, and rubella 97%. So MMR is contraindicated if there is a history of anaphylaxis to the vaccine or its components. It is contraindicated for those with life-threatening reactions to neomycin, and common reactions include arm pain, fever, rash. Rare reactions are seizure in children. Now, tetanus, diphtheria, and acellular pertussis, also referred to as Tdap. The schedule is for adults with 1 prior vaccine, 1 dose with booster is recommended. For adults without prior vaccine, however, I make reference to the published schedule for catch-up. Lastly, it is indicated in the 3rd trimester of every pregnancy. Regarding efficacy of Tdap, for adolescents, 73% in the first year after vaccine. The general efficacy is 34% after 4 years of vaccination. Evidence is lacking for significant benefit of a 2nd dose at 5 or 10 years post-vaccination. Therefore, Tdap is usually given once, and then TD, or tetanus, is given when indicated. Safety for Tdap, contraindicated for anyone with a life-threatening allergic reaction after a previous dose, contraindicated in those who have had coma or seizures within 7 days of administration, caution in those with seizures, encephalopathy, defer until neurologic status is stable, caution in Guillain-Barré, or if moderately or severely ill. Common reactions include pain, redness or swelling at the injection site, mild fever, headache, nausea, vomiting, or diarrhea. Regarding vaccine benefits, for influenza, there's a shortened length of hospital stay, reduced risk of ICU admission, and a reduction in risk of death. For measles, mumps, rubella, measles is highly contagious. Up to 90% of close contacts become infected. There has been a 99% reduction of cases since vaccine use. Prior to 1963, estimated cases were 3 to 4 million per year, with a death rate of 0.1 and 0.2% from encephalitis, which accounts for about 500 to 1,000 cases. Mumps can cause deafness, meningitis, ovarian and testicular complications, and rarely death. Rubella carries a risk of birth defects and miscarriage. For Tdap, the vaccine prevents the condition, which is rare but life-threatening. It prevents whooping cough, which is a mere nuisance persistent cough in adults, but a life-threatening condition in children. Diphtheria complications include airway obstruction, myocarditis, polyneuropathy, and kidney failure. Lastly, for varicella zoster, non-immune adults are at risk for systemic infection that include pneumonia, brain infection, bleeding complications, and predisposition to bacterial skin infection. So what happens for an exposure incident? First, let's start with the definition. An exposure incident is defined and requires all of the following. Number 1, an employee has been exposed to an individual who is a case or suspected case of a reportable ATD, or to work area equipment that is reasonably expected to contain an aerosol transmissible pathogen. Number 2, the exposure occurred without the benefit of applicable exposure controls required by the ATD standard. And lastly, it reasonably appears from the circumstances of the exposure that transmission of the disease is sufficiently likely to require medical evaluation. Healthcare providers who determine that a patient or client under their care has contracted a reportable airway transmissible disease must report the case to the local health officer. Assuming one of these events, an exposure scenario analysis is required, and for that I refer to the ATD policy for its requirements. The clinic is required to determine if other employees or other employers were also exposed to the ATD case. Regarding notification, within 96 hours of becoming aware of the potential exposure, the clinic must notify their employees who had significant exposures of the nature, date, and time of their exposure. Post-exposure medical evaluation. This will be made available to the exposed employee, and the physician or licensed healthcare professional will provide a written recommendation regarding the necessity of removal of the employee from regular duties. Access to written procedures are required by the standard. The ATD policy hard copy will be placed in the unit. A PDF or Word format copy will also be made available. Online resources for ATD and the relevant links are here given. And lastly, volunteers in any given work designation or duty can participate in an annual review of the ATD policy. Our airway transmissible disease policy includes an index which has 4 illustrations that are included in a handout for this presentation. These include sequence for putting on PPE, how to safely remove PPE, Figure 1, example of correct markings on NIOSH approved filtering facepiece respirators, Figure 2, example of NIOSH approval label. So in order to finalize all that is necessary to implement the ATD policy, there are a few items to look at. The first, and this is found under Section 1 of our policy, is the administrator and designee. And verbatim according to our policy, here it is. The clinic shall designate a person as the administrator who will be responsible for the establishment, implementations, and maintenance of the written procedures to control the risk of transmission of aerosol transmissible diseases. The administrator shall be knowledgeable in infection control principles as they apply to the facility, service, or operation. When the administrator is not on site, there shall be a designated person with full authority to act on their behalf. And finally, some to-do items in regards to forms. A post-exposure medical evaluation form may be required. However, the alternative to this is just to look at the requirements within the policy for documentation relevant to this aspect, or to create a template within our electronic medical record for its requirements. We require vaccination policies for the required vaccines. And in regards to source control posting and supplies, we need the posters in English and Spanish, hand sanitizing devices, source control masks, whether they be procedural or surgical. We will be doing fit testing for volunteers yearly. And lastly, we are required to do training. And this is done at the outset of participation and yearly thereafter. Thank you for your attention. And now we leave time for any additional questions.